So I'm Larry Gold, and I want to thank you all for coming, and I'll thank you again at the end of my introductory thing. I'm kind of amazed to see this many people here at 8:30 in the morning. I used to teach at 8:30 in the morning. There was no one here ever, right here in this room, actually. I'm going to make some introductory remarks that I think are intended to frame the discussion we're about to have for 2 days, and it worked. So I'm going to start by a few slides to make sure that we're all speaking the same language. I want to say you're all supposed to turn off your cell phones. I've just heard from a friend of mine that at his daughter's wedding, the rabbi made that announcement, and as he was pronouncing the man and wife, the rabbi's cell phone rang. So I've turned mine off. Please turn yours off. Personalized medicine, turns out if you talk to people who think they're working on personalized medicine, each of them will have a definition that is different from every other definition. And so this is my attempt to frame what we mean by this, and it's pretty obvious. It's very high level. To begin with, it's not medicine, it's actually some sort of lifestyle choice. That's the beginning of that, encouraging each person to live properly. And we can do a better job than we do now by actually using data of some kind to find out what you should eat as opposed to what you do eat and how you should live rather than how you do live. And so that's kind of, easy. And today that's just about exercise and a good diet a little bit, but we don't know much about that. The real definition starts with the second bullet, which has to do with diagnosing both the risk of disease for every person and the initiation of a disease that person may or may not be at high risk for. So it's about evidence-based diagnosis, and most people agree with that definition. And then the equally important third bullet, equal to at least the second, and probably eventually the first will be important also, is that you'd like to be treating people, each person, as effectively as possible. The obvious examples are, cancer, you would like to be detected, have it known early so that surgery saves your life, for example. So it turns out that you can go a little bit more granular in this framing definition. There's about, in most ways, in most diseases, there are 3 different kinds of treatment that you might do. The first one, I live in Boulder after all, is to have someone put their hand like this and tell you you'll be fine, which is the first one, but it's an important thing. Sometimes no treatment is appropriate. Not just because you're going to die, but because you're going to get better. And so you need to have some sort of support for that set of decisions, the right decision. Sometimes surgery is the right move, and you have to find the right type of surgeon, and you have to have the right time for surgery. Today, it is almost always true that a person diagnosed with a tumor is told to immediately have the thing resected if it's resectable. And in fact, it's pretty hard to find an experiment, because it wouldn't be allowed probably, in which people are told to wait a month before that surgery. A kind of an interesting experiment. So in fact, we don't know whether it's better or worse to give your immune system a chance to, for example, recognize your tumor before resection. So the right time and the right kind of surgeon. And then, of course, for those things that are pharmaceutically driven, you have this notion of the right drug and the right dose and the right time always again. So personalized medicine is really this kind of set of rights, Bill of Rights, I called it to be cute. And of course, every physician practicing medicine today thinks he's doing personalized medicine. I mean, your patient comes in and you do exactly this set of thing. And really the difference is what kind of evidence one uses or might use. So this is, this is Shane DeRolf, one of the organizers, asked me not to show this slide. The purple is the truth. This is from Jim Harrison, Most of you don't know he's one of the world's great food writers, so I happen to be reading this book. Don't you love this? People are enamored with the drama of their own personal survival, which is always a succession of temporary measures. That's a little bit grim, but that's what personalized medicine is about making those temporary measures as strong as we can. Here's a fact that everyone knows. I'm okay, I hope. This got lost in the debate. It's been said by a zillion people, and so everyone in this room knows this, but no one wants to talk about it. When Dick Lamb gives his talk, trust me, he will talk about this. It is kind of horrifying. So this is real, these are real data. Up at the top left, you can barely see it, is the spend per person in the United States, $7,200 per person. The rest of the developed world, all these blue lines, average about $3,000. So you'd think that the best healthcare system in the world, which is what we always say, might do something. You might live longer. You might be taller, whatever you think is important. And it turns out we're about right in the middle. So by the easiest thing to measure, death, we're not doing so well. Now, you've all heard the debate, but what is being distributed, David Snow will talk a lot about the distribution of medicine and medical practice. Based on, we distribute some things very well, but they are not life-saving, at least according to these data. So here are the goals of personalized medicine. My goal. I don't know if this is shared by everyone, but it's certainly my goal. The red curve shows that over time, I just did this, with PowerPoint, just futzing around. Quality of life gets worse. Duh, right? I mean, you hurt more, you got things wrong with you, and eventually it gets really bad and ends. And so people who think hard about this, without wanting us to live forever, so this is not showing us living longer, wouldn't it be nice if we had a quality of life that extended until, say, you were 68 or 75 or 93 or whatever it was, you were vigorous, and then you went to sleep, and in the morning you just forgot to get up. That's kind of the implication of this thing. And a friend of mine from Somologic, Nebojsa, came running in, Nebojsa Janic, who's here today, came in and said, of course, this shaded area here, this is the improvement to the quality of your life, if you could do this, right? That's a simple way of thinking about what you're really trying to do. It's a sort of a net health advantage over a lifetime. And so, you can argue about whether you want a day to be with your family or 5 days or 7 days, but you don't want, at the bottom of the red, 11 years of poor quality life, I think. So that's kind of the goals of, in my view anyway, of personalized medicine. The idea also is, of course, it has to lower healthcare costs. The whole idea here is if you're spending twice as much or 2.5 times as much as everybody else in the world, you ought to attack that problem also. So you want both the green or blue, whatever color that is, curve, and then you also would like cost to come down. I think that I had something to do with the speakers that came, but mostly it was up to them. And I know many of them. I've met perhaps half of them. Some of them I know very well. And I think that most of the speakers, anyway, all of them, share these desires. Or maybe we'll hear about that during the 2 days. But some of the speakers think these goals are possible. I do. That's why I'm still working, actually. I think this is a right set of goals for a scientist. And a few of our speakers think this is many years away, which I also don't agree with. I do not agree with that. I think the reason that I wanted to do this, we wanted to do this, was that it's possible that we could reach something like this a lot more quickly than most people realize. That's why we're here. So everyone asked me, apparently I've been interviewed a fair amount about, it's kind of funny, nobody ever asked me anything before they interviewed about, what is this about? Why time? So originally the title came from one of the speakers, and we thought he was suggesting a title for the symposium. Actually, he was suggesting a title for his own talk, and then we stole it, and then he made another. I won't tell you who it was, but thank you very much for your, you know who you are. It was great. And so why time? What's this time stuff about? And you know, everyone would have it's a broad enough topic. You can say anything you want. And this is a list of things that are just in the way. There's just a ton of stuff in the way. And this list that I made in 5 minutes that you can read, I won't read it to you, is just a fraction of the list. There's more, okay? You can make up other things. And so the idea here, for me anyway, the idea of getting together for a couple of days is to see if it's possible, not by defining David Snow, for example, as the king. We don't need David to be the king. I don't think he wants to be the king, but there has to be a way that there is a way to make things happen more quickly than they seem to in the healthcare system today. So in my abstract, I said a little bit about the ins and the outs of personalized medicine. I want to show you in the last, I don't know, 10 slides for 5 minutes or 8 minutes, what I mean by that, because I mean something very precise and scientific. And so even though the slides are meant for all of you, the science behind the slides is, I think, serious. So I have a belief, ins and outs, by the way, refer to the mouse as an inbred animal for medical experimentation, and us completely outbred. The bicycle that let people get from one town to another in England was the beginnings of outbreeding, I think. Okay, so what do I mean by the complexity of human life and filters? So the genome, the thing we'll hear more about, is vast, sequenced. We know a lot about. We know it all. We know all the letters. We know all the letters for 20 people. And we actually know the average letter for 20 people today, but it's going to keep getting deeper and better. And it's extraordinarily complex. And so that DNA stuff, our genes, is really complicated. And I think there are filters that cause most of human biology to end up being played out by small numbers of networks or systems. And I'm going to say a little bit about that so you know what I'm talking about, because it is essentially the framing discussion, the framing science about personalized medicine. So this is DNA. I want to thank, it's a high resolution picture. It's actually whatever it is. And this was understood 60 years ago, 1953, was when the famous paper by Watson and Crick was published. 2.5 pages long, stunning work. And then all the rest of us spent the rest of our careers working out the details. That was okay, that was good. And it turns out that we know an enormous amount about how genotype, DNA, gets converted to phenotype. And there are lots of discussions among scientists about what we mean by phenotype. Some people mean behavior. Well, that's phenotype. But let's try to keep it molecular because it's important since we're going to talk about measuring stuff. So the chromosomes have the DNA in them. There's a picture. There's DNA. And DNA gets transcribed by a set of enzymes in your cells into mRNA. And mRNA gets translated into proteins. That picture on the right, lower right, is a protein. And mutations in DNA sometimes, which I underline, cause changes in proteins. But that's pretty rare. Sickle cell is an example of a disease in which a change in the DNA changes a protein, hemoglobin. But it's rare. So the genotype can change the phenotype, but most human mutations are silent, or at least we think they're silent. And maybe during the course of this symposium, we'll find out a little bit more about that. So if they're silent, what that means is genotype rarely impacts phenotype. So part of the thing we're going to talk about for these 2 days is whether as a medical practice we should know genotype only or genotype and phenotype, or what should we be measuring? And so that's part of my framing discussion, and it will come up this whole morning, always done so everyone understands what we're talking about. So this is the parts list, and it tells you, it's the same slide, it reminds you of how vast your genome is. So the genome is 3 or 4 times 10, 3 or 4 billion base pairs. So I made a little box in the structure of the molecule up there. That purple box is a base pair, sort of. And those are the letters. So every time somebody says to you A, C, T, or G, those are the things that are the letters of DNA. And there's a big, long run of them sitting in long DNA molecules that are sitting in those chromosomes you see up there. There's only about 20,000 human proteins. People argue about that. And I think of human proteins as a way of measuring phenotype. And I'm going to show you that in a second. And so that's a big reduction in dimensionality, and maybe will give us a chance to see, through this kind of notion of a filter, give you a chance to see that you can study people in a less complex format, proteins versus DNA sequence. So this session was called Omics 101 or something, and it turns out that the technology that's made the world different for scientists and doctors and healthcare practitioners is today you can measure a lot of things easily. So this slide that you're looking at is actually one from SomaLogic in which proteins are measured, but in fact on that very piece of equipment, which is a piece of equipment from one of our sponsors, from Agilent, one can measure a lot of things. You can measure mRNA levels, you can measure changes in DNA, you can measure a lot of things. So this slide says, wow, omics, this kind of thing of measuring DNA or RNA or protein concentrations or sequences, is now available to the research community. And so the problem is, for us, is what should you measure and how useful is it going to be, not can we make the measurements. This is all now standard stuff. So I have a little bit more to say about ins and outs, inbreeding and outbreeding. And this is kind of funny, but so this is an experiment that used to be the experiment to define a drug to take into the clinic for as an anti-cancer drug. This experiment it doesn't work very. Let me say what it says up there. You take mice, 100 mice. They're essentially clones. Inbred mice have been bred together. They're not clones, but they're a lot closer to clones than we are, okay? We in this room are very different at the DNA level. They're less different. And then you give them cells that you've made over here in a bottle, cancer cells, and then you treat half the mice with an anti-cancer drug, and if it's a good preclinical evaluation, you just weigh the tumors or measure them with calipers, whatever you want to do, whatever the measurement is of size. And if the drug is successful, Avast, and a very important drug, gave data like this right away in mice. And that looks wonderful. I mean, it is wonderful. And so what used to happen is, based on not much else, people would file an IND and start a human clinical trial. So we're a little smarter than that now. I mean, the joke. You don't want to be a mouse doctor, you want to be a real doctor, right? So now let's imagine what the data are for human clones, real clones. It's important to think about it. Imagine that, okay? So there's 5 of them. Do you remember them? It's a long time ago. They were identical quintuplets. This is before in vitro fertilization. Bang! 5 daughters. There they are, identical at birth, actually at about 2 hours after conception. Those 3 of them later, the other 2 had already died, And here's, if you will, their outcomes. One had cancer, one died of a blood clot in her brain, and one had a seizure of some kind a lot earlier than everybody. They didn't have, these are not, there's no concordance here, is what I'm telling you. There's no concordance. So you think, come on, it's just 5 people. Who knows? You know, who knows what happens in a convent? I don't. It's not my tradition, so I don't have anything really to say about that except some smart-ass remark. But you can't do that. But people have studied this. They've studied the concordances between identical twins and non-identical twins. MZ is the identical twins. And the concordances are low. And in fact, the concordances of disease are worse than this because there's a time window in which you're allowed to be concordant. So if 2 identical twins get the same disease 48 years apart, you don't want that to count as concordant. That's not fair. I mean, we're talking about both genetic risk and disease initiation. So the window in this data from this guy who used to be here in Boulder, Bob Plomin, is the concordance that is used in this graph is a little cheaty. They used, I think, from the paper, about 5 years for the monozygotic twins, and actually used a slightly longer one. So that's even worse. So it's not a perfect thing. But when you look down here at the cancers, you think, wow, it's not so great. And here's more data. Look, make sure you notice that the ordinate, the concordance ordinate, only goes up to 0.3. And you kind of get this feeling that there's not much difference between the monozygotic twins and the dizygotic twins. So you don't end up thinking that this is the whole ball game by any means. So this is the lessons in words. And down in the quotation marks are things that we've been reading about because you've got to be interested in this. And sometimes you see concordance. There's a report from Coe et al., doesn't matter what the paper is, that monozygotic twins that each got ovarian cancer, so you think that's concordance. They were different kinds of cancer. So come on, that's not, well, let me say it's risk maybe, but not destiny. Okay, which is the thing. And Finton Steele, one of my best friends on this planet, is going to be the bookend, and I've seen his slides this morning, and he's going to give you a more scholarly view of this, trust me. So I want to show you the good news, just so you're thinking about the good news. This is not about, isn't it dismal? I'm not making a speech about genotype is useless. I'm not doing that. I'm a geneticist originally by training. I study that stuff. I like it. Just think about this simple-minded experiment. This is an experiment that we did actually at SomaLogic in the last half year, collaborating with a pathologist named Jeff Baird from Washington State, Seattle. And it's an incredibly simple experiment. He got the excised lobes of lung from 6 patients, and the patients were both men and women. They had a wide age range, all the stuff it says, and they had, not only did they have lung cancer, but they had the 2 different main kinds, squamous cell and adenocarcinoma. So those are the 6. And there was early stage disease and late stage disease. So you couldn't ask for a bigger spread. You could. It's only 6 people. And if you do the calculation that's in my abstract, the calculation says that there's a lot of fertilized egg possibilities. You can go do that math yourself. And so people are really different, and these really different people, genotypically really different, had these very different genders and these very different cancers at very different stages. And we analyzed the proteins that were made by the tumor and in healthy tissue away from the tumor. And it turns out that when you do that, almost all the proteins are the same. That's the left side. That's the 6 data for the tumors, and then the blue and the green are for the adjacent healthy tissue. But then you found a few proteins that are practically not made in the tumor, in the middle, and a bunch of proteins that are made at higher levels in the tumor. So you have this extraordinary moment where all this genotypic complexity gets filtered through biology and pathways and networks and all these words into something that looks similar. And of course, that gives you a chance to treat disease. And down in the bottom for the scientists and the crew, it says, wow, you could do a replacement in the middle and get that red protein up. If you know how to do that, you could antagonize the red protein on the right and treat the tumor. So these are potential targets for therapeutic intervention. So the lesson is that vastly, this is word for word from my abstract, vastly different genomics might push people toward disease, push people toward diseases with common attributes. Complex genotypes are about risk and some other important things, including drug dose. But I think similar phenotypes are going to provide actionable information, and genotypes and phenotypes are going to get combined to make personalized medicine robust, and that's what this symposium is about. So, a few ground rules, and then I'll sit down and let Leslie take over. We're going to learn a lot. We've asked all the speakers to try to speak English. This is very hard for scientists to do, just in case you haven't noticed. You're free to interrupt. I plan to. If I don't understand something, I'm going to be miffed. A word I didn't say yesterday in my interview, apparently. So I don't want to be miffed. I don't want to lose whatever's getting said, and you don't have to either. So please don't. Feel free to interrupt. We've got enough time. Each speaker has 50 minutes. And some of the people will spend 20 or 30 or 40. And so there's time for questions. We're doing that. Yes, and in the bottom thing it says, hopefully, this is about Jim Harrison again, hopefully we're going to bring open minds to the dialogue, and this is one of my favorite slides. You can read it yourself. Turns out having an open mind is difficult. It's difficult to do. It's easy to say you have an open mind, but difficult to actually have one. And so this is a quote apparently from Tolstoy, but I took it right out of, this is Michael Lewis in The Big Short, sorry, not Jim Harrison. The Big Short is a great book. So this is the last slide. Of course, I want to thank all of you for coming, and I want to thank the co-sponsors from the university, the speakers. It's an astonishing group of people that have come to here to talk to us and to participate in the dialogue. The moderators, they're all in the program. There's an organizing committee. I didn't put their names up, all 9 of them. Carissa, my daughter, when she realized that this was a train wreck about to happen, which was about a month ago, she enlisted more help, and she did it after we made the program. So their names, they're here today. There's a bunch of sponsors that we have signs up down below. The sponsorship was kind of remarkable, and it's in the programs. People actually said, well, we can help, and they did help. So we didn't have to do all this through the university. That was really